Okay, dear ladies and gentlemen, let me introduce you Dr. Manuel Казанова from United States. First of all, good afternoon to everyone, dear colleagues, respected parents of children with autism spectrum disorders. It is my great honor to introduce you Dr. Manuel Казанова, who made his residency training in neurology and then spent 3 years doing a fellowship in neurobiology at the Johns Hopkins Hospital, one of the most famous hospitals in the United States. During his stay at the Johns Hopkins Hospital, Dr. Казанова was in charge of pediatric neuropathology, a fact which kindled his interest in developmental disorders of the brain. His clinical experience was enhanced by appointments as either a consultant of staff neuropathologist at Sinai Hospital, Maryland, the North Charles Hospital, and the DC General Hospital. He spent several years as deputy medical examiner for Washington, DC, where he gained valuable experience in the post-mortem examination of sudden infant death syndrome and child abuse. His expertise in the field was recognized by honorary appointments as a scientific expert for the Armed Forces Institute of Pathology and as a professional lecturer for the Department of Forensic Science at George Washington University. Dr. Казанова spent 8 years helping to establish 2 of the most successful brain banks in the country, the Johns Hopkins Brain Research Center, 3 years, and the Brain Bank Unit of the Clinical Brain Disorders Branch at the National Institutes of Mental Health, 5 years. Dr. Казанова is the recipient of the Presidential Award of the American Medical Association, National Research Service Award by U.S. Public Health Service, a Stanley Scholar Senior Scientist Award, Winter Workshop in Schizophrenia, and honorary doctor's degree, honorary visiting professorship, and contributing peace award by Families for Effective Autism Treatment. He also serves in numerous scientific advisory boards and as an editor for over a dozen journals. At present, he is the Smart State Chair for Child and Neurotherapeutics at the University of South Carolina. Dr. Казанова, before I gave you your microphone and your presentation, I will say a few words about this is our second webinar, which we as a Macedonian Scientific Society for Autism organized. And I'm very honored to have a guest, my old friend, my old internet friend, I would say. We know each other almost 15 years ago. Dr. Казанова was helped me in a lot of reviews in my former journal of special education and rehabilitation, and now he's a board member of Journal for Real Touch Therapy and Development of Diversities. And I want to express my gratitude to him, and also I would stress your attention that today we celebrate 3 years since I have been admitted as editor-in-chief of this journal. I invite all of you, dear colleagues, to write your paper if you have some scientific or some professional paper in our scope. Okay, Professor Казанова will talk from his computer on English, and our assistant, our assistant in journal, Mrs. Andrea Ivanovska, will share her screen on Macedonian. So today we will not have a simultaneous translation into Macedonian, but you will have a chance to see his slides on Macedonian language, and also I will share with you key notes of every slide in the chat. Okay, now I will give the floor to Dr. Казанова. Please express your presentation, and I would, and also we would like to see your presentation. I'm impatient.
Okay.
to see it.
Thank you very much for the kind introduction, Vladimir. Good afternoon to everybody, or evening as the case may be. I'm very pleased to be here with all of you and to be able to share this presentation, which is titled Transcranial Magnetic Stimulation, or TMS, in autism. This is going to be a review of some of the research conducted mainly in my laboratory and the translational efforts we have made using this technique in clinical trials. Is there a scientific basis for using TMS in autism? What is TMS? What have been the preliminary results of these studies? Stay with me, and sometime during this lecture, I will try to answer these questions. But before I begin, I would like, first of all, to express my gratitude for the invitation that made this conference possible to my good friend, Professor Vladimir Trajkovsky, President of the Macedonian Scientific Society for Autism and Editor-in-Chief for the Journal of Reattach Therapy and Developmental Diversities. I would also like to acknowledge my appreciation for all of the parents, autistic individuals, and healthcare providers that are joining us. It is your interest and support that has always motivated me in my autism research. Next slide. Several years ago, Declan Murphy, a professor of psychiatry at King's College in London, gave the plenary lecture for the International Society for Autism Research. The theme of his lecture was the lack of proper treatments in autism. In reviewing the medical literature on available therapies in autism, Declan found an absence of curative treatments. Rather, all of the treatments were symptomatic interventions. In other words, all of the therapies that he reviewed for autism were supportive in nature, targeting some of the symptoms, but not the underlying cause. In this regard, therapies were aimed at increasing patient comfort and improving their quality of life. But at the end of the day, week or month, the patients would remain with the same predispositions to the symptoms that brought them to the physician in the first place. Declan concluded his lecture by saying that unless treatments focus on the cause of autism, on its pathology, there could never be the possibility of a curative treatment. In this sense, we will provide a small review of those pathological findings that have been reported in the brains of autistic individuals in order to determine if any of them can serve as a target for possible interventions. It should be remembered that autism is known as a neurodevelopmental disorder. And as such, the development of the nervous system is affected, thus causing the symptoms of autism. Therefore, before we talk about the changes in the brains of autistic individuals, we will have to talk a little bit about brain development. Next slide. Theodor Hermann Meiner was an Austrian psychiatrist, neuropathologist, and neuroanatomist of the 1800s, who maintained the belief that disorders of the brain development were responsible or could provide a risk factor to psychiatric disorders. At the time, Meiner didn't know much about brain development. He said that the brain development was similar to a complex ballet where the performers were the neurons. Fortunately, we have learned a lot more about brain development, especially in recent decades of research. During the formation of the cerebral cortex, those cells that are the progenitors of neurons migrate from the periventricular location, labeled on this slide as the periventricular germinal zone, to their final destination within the cortical plate. The migration of these precursor cells is called radial or tangential, depending on the orientation the cells take during migration with respect to the surface of the developing nervous system. Cell migration within the periventricular germinal zone begins before the 6th week of gestation. At that time, neuroblasts, or the precursor cells of neurons that migrate to the cortical plate, do so along glial fibers that are radially arranged. And when they reach their destination, they detach along multiple layers. Those arriving earlier break off in the deeper cortical layers. And by that, I mean those closest to the white matter. Alternatively, the migratory cells that arrive later break off in progressive, shallower locations or closer to the surface of the brain. Interneurons or inhibitory cells arise mainly from the medial and caudal eminences and migrate tangentially to reach their final destination in the cortical plate. These inhibitory neurons are first established in the lower cortical layers and mature along ascending layers next to the pyramidal cells with which they establish contacts. The distance traveled by the neuroblasts that migrate tangentially is much greater than that traveled by the precursor cells that follow the radial pathway. In this way, tangential migration allows future interneurons to reach destinations far removed from their origin sites. This route, that we could call tortuous, expands the window of opportunity or time during which the migration of neuroblasts may be disturbed. Next slide, please. In autism, the presence of malformative lesions, like clumps of gray matter located where they should not be, so-called heterotopias, in conjunction with an increase in cell density at the junction of the gray-white matter substance, illustrated here on the right side of the figure, the presence of a minicolumnopathy, as well as the presence of focal cortical malformations, all suggest a neuronal migration disorder. Abnormalities of cell division and subsequent migration are common in autism spectrum disorders, or ASD. In fact, I have to point out that in recent series, using full brain sections along the rostrocaudal axis of the brain, Jerzy Weigel and colleagues reported the presence of these neuropathological markers in 92% of the autopsy cases that they studied. The malformative or dysplastic exchanges are frequent enough for some researchers to propose their use in subtyping or stratifying ASD patients. Next slide. The confluence of tangential and radial migratory currents into the cortical plate results in a series of cellular associations characterized by functional dyads between neurons that are excitatory, better known as pyramidal cells, and those that are inhibitory, so-called interneurons. The overlap and interdependence of these cellular dyads, stacked one on top of each other, results in a unit of anatomy and function called the minicolumn. Rafael Lorente Denot was the first person to discern the functional role of these vertical cylinders when he stated that all of the elements of the cortex are represented in them, and therefore can be called an elemental unit, in which theoretically the whole process of transmitting impulses from the afferent fiber to the efferent can be achieved. Mini-columns are thought to contain a canonical circuit that repeats itself along the cerebral cortex, thus providing a basic similarity of design and function. In the next slides, I will talk about how these modules or mini-columns are structurally and functionally abnormal in autism, and how these results gave rise to the use of transcranial magnetic stimulation in this spectrum of disorders. Next slide, please. Postmortem studies of mini-columnar morphometry in autism indicate noticeable differences compared to neurotypicals. These studies indicate compartmentalization of mini-columns with a significant reduction in area in the peripheral neuropil space, illustrated in the figure under the abbreviation NS. By way of contrast, its central compartment is relatively preserved. The periphery of the mini-column is populated by inhibitory cells that help establish the so-called lateral or surround inhibition. Now, I will emphasize this point, which is very, very important, that the periphery of the mini-column is populated by inhibitory cells that help establish lateral or surround inhibition to the mini-column. Mountcastle described this compartment as giving the mini-column a strong vertical flow of inhibition. Peripheral neuropil abnormalities in autism therefore suggest an inhibitory deficit. It is therefore logical to think that in autism, the inhibitory cells that occupy this space at the periphery of mini-columns are diminished in number and or function. And in addition, that correcting this inhibitory deficit could therefore provide a therapeutic target for autism. In future slides, we'll show how we targeted this inhibitory deficit with transcranial magnetic stimulation. Next slide, please. Having an idea similar to Mountcastle, who proposed a strong vertical inhibition flow at the periphery of the mini-columns, Sethen Gotay and Arbib described the function of the peripheral mini-columnar compartment as a shower curtain of inhibition. In autism, a faulty shower curtain of inhibition, talking about a decreased peripheral neuropil space in mini-columns, allows stimulation to spread from one mini-column to adjacent mini-columns. The end result is to decrease the signal-to-noise bias of the cerebral cortex and to create a cascade of excitation that could provide an explanation to the sensory problems and seizures often observed in autism. In the illustration, we emphasize how a shower curtain normally keeps the water inside of the bathtub. If it is defective, the water splashes the floor outside of the bathtub. Similarly, when the mini-column's shower curtain of inhibition is defective, as in the case of autism, the signals that are conducted in the center of the mini-columns are disseminated, diffused to adjacent mini-columns, thus creating a cascade of excitation. Information contrast is thus diminished. And often, small signals that could have been construed as a noise overrun the system. They overpower them. One analogy that can help us understand the proposed deficit of inhibition in autism is to imagine a bundle of copper wires conducting electricity. Each cable is isolated from its neighbors by a non-conductive or insulating material. If this insulation is defective, copper wires could touch each other to create an alternate path for the electricity to flow. In the worst case scenario, when the alternate path is one of much lower resistance, the same could cause a short circuit. The short circuit is an unintended route that detracts from the normal operation of the circuit and, in some cases, can even damage it. The short circuit provides a preferential pathway that overrides anything else that may be happening in the system. In the case of autism, noise or an unintended signal may in this way overpower the processing capacity of the cortex. Next slide. This slide provides the results of a computer modeling study from my research group. This effort was aimed at trying to visualize the lateral inhibition of mini-columns by plotting the net effect of the activation of one of these modules based on the tangential distance to the cortical surface. When an idealized and healthy mini-column is active, its short-range output is a combination of excitatory signals, illustrated here with the red color, and inhibition, illustrated here with the blue color. Together, they create the profile of a Mexican hat model of excitation inhibition. This is what is expected normally. Pathological mini-columns, those where an inhibitory deficit procreates a cascade of excitation, one where the activation of any one tends to activate a whole set of mini-columns, results in a profile of a top hat. This is what happens in autism. In a neurotypical individual, information processing results in a profile having multiple values, the Mexican hat model. While in autism, much of the information ingrained in the variability of excitation is lost, thus resulting in a digital or binary system with two possible states, either excited or inhibited. That is the top hat model in autism. You could say that the brain of many autistic individuals are wired as a switch that allow you to go from on to off and vice versa with little mediating in between states. Currently, both the electroencephalogram or EEG and tactile processing studies indicate lateral inhibition abnormalities in individuals with ASD. In ASD, several lines of evidence suggest the presence of a cortical inhibitory defect. Postmortem studies in ASD have shown a reduction of GABA inhibitory receptors in the cerebral cortex. Moreover, immunocytochemical studies have located this inhibitory deficit to a subset of inhibitory cells containing a calcium-binding protein called parvalbumin, usually abbreviated as PB. Next slide, please. John Ratey is an associate clinical professor of psychiatry at Harvard Medical School and an internationally recognized expert in the field of neuropsychiatry. Among some of his writings, he has tried to describe what could happen to an individual whose brain is bombarded by excessive stimuli. The relevant example being provided by the deficit in the shower curtain of inhibition previously described in autism. He says the following. First of all, what the researchers found is that, in fact, the overload of stimuli is devastating for the brains, for the ability of oneself to maintain its cognitive functions. Entirely normal people who are severely overloaded, especially by unpredictable and uncontrollable stimuli, may show poor functioning, high physiological stress, internal chaos. These people take impulsive actions and maintain a lower level of adaptation to life's challenges. This is something that certainly incapacitates the individual, limiting the way in which a person, thus affected, can react and adapt to his or her environment. And second, John says that because research shows that prolonged states of sensory overload or noise are actually traumatizing, we can conclude that patients with severe mental disorders are actually being traumatized by their own brains. This point underscores how essential it is in these cases to offer treatment as early as possible. In essence, the earlier the treatment, the better the prognosis. Next slide, please. Cell destination specification studies have shown how interneurons develop in an abundance of cells that vary from each other in terms of their morphology, neurochemistry, and electrophysiology. In neuropathology, the subtyping of interneurons has been done using surface markers, that is, calcium binding proteins. When comparing brain tissue samples from autistic individuals and neurotypical subjects, controls, an immunocytochemistry study by Veronica Martinez Cerdeño revealed a significant reduction in the total number of parvalbumin PV positive cells in all areas and cortical laminas examined. These cells are indicated in this slide as dots with a magenta color. Positive PV cells account for approximately 40% of all interneurons and includes both chandelier cells and basket cells. This is of clinical significance as the function of these PV positive cells is significantly diminished in the prefrontal cortex of numerous psychiatric conditions. Among them, it is worth mentioning schizophrenia, Alzheimer's disease, and bipolar disorder. I should also point out that there are animal models of autism showing a correlation between decreased PV expression and the behavioral deficits characteristic of the ASD phenotype, of the autism phenotype. This clinical pathological correlation makes me believe that a loss of PV positive cells is a true core feature of autism and a possible target for therapeutic interventions. Next slide, please. As I said in the previous slide, immunocytochemical studies by Veronica Martinez Cerdeño have shown a significant reduction in the total number of PV positive cells in all cortical areas examined from individuals with ASD. This neuropathological finding is of great significance. And for that reason, I will expand a little bit more on it, especially in regards to how this pathological finding relates to a particular bandwidth of brain wave oscillations called gamma. Rapid inhibition by PV positive cells helps regulate the activity of pyramidal cells, prevent uncontrolled arousal, refine receptive fields, and even synchronize the firing rhythm of neural populations responsible for gamma oscillations. Among neurons that are PV positive, basket cells are highly interconnected through chemical synapses and gap junctions. The network formed by these cells results in synchronous triggering manifested as high-frequency gamma oscillations. It is worth emphasizing some of what we have learned so far before moving forward. A pathological increase in gamma oscillatory activity, as noted in autism, reflects an imbalance in the homeostasis of excitatory inhibitory cells in the cerebral cortex. This inhibitory deficit, like gamma oscillations, may be the result of a decrease in PV positive cells. Next slide, please. Synchronous recruitment of PV positive interneurons generates, as we have already said, gamma oscillatory rhythms that arise during the execution of cognitive tasks, especially those functions referred to as executive functions. These are functions that allow us to associate ideas, movements, and actions to perform more complex tasks. 2 points of importance that I will underline and which appeared on this slide. First of all, modulation of gamma oscillations going from 30 to 60 hertz or cycles per second has been associated with cognitive performance, particularly when stimulation is carried out over the dorsolateral prefrontal cortex. And second, therapy with transcranial magnetic stimulation, or TMS, over this area of the cortex can normalize gamma oscillations. These 2 observations gave us the idea, in part, of using TMS over the prefrontal area of the brain as a possible therapy for ASD, and of using gamma oscillation in conjunction with other behavioral examinations as outcome measures. I would now like to take a brief detour in order to expand on the clinical implications of gamma oscillations in autism. These oscillations are the ones that allow us to associate different elements of our perception into a whole. Temple Grandin, a well-known autistic person, has said that she has trouble trying to accept how a Chihuahua and a Dalmatian belong to the same classification of animals, both of them being dogs. In autism, as we have already said, gamma oscillations are abnormal. These are the oscillations that allow us to put objects of our environment in context, such as the Chihuahua and Dalmatian in the case of Temple Grandin. These oscillations are the ones that help us generate a whole or gestalt out of an experience, to recognize a face as one belonging to that of a friend and not to a detached set of eyes, nose, and mouth. Gamma oscillations, therefore, help us to have an adequate perception of reality and make appropriate decisions. Again, I emphasize that these oscillations are abnormal in autism and could serve as an excellent outcome measure when judging the efficacy of an intervention like TMS. Next slide, please. The analysis of electroencephalographic recordings allowed the identification of bands of brainwave frequencies, as well as their potency or power. For gamma oscillations, changes in the power of brainwave activity are called evoked when linked to a provocative stimulus and when they persist within the first 120 milliseconds after the start of the stimulus. The evoked gamma is thought to represent the processing of information within a confined cortical field. In contrast, for gamma oscillations, the so-called induced component represents the processing of information across neural networks in different cortical regions. This component of gamma activity, the induced, has a variable onset, that is one that is not locked to the stimulus and usually begins around 240 milliseconds after the stimulus. Gamma oscillations are usually measured in association with provocative stimuli, figures of illusory or subjective contours, the so-called Canisa figures, which evoke the percept of a shape, produce gamma oscillations during visual cognitive tasks. In autism, EEG recordings, when presented to the patient with Canisa figures, have shown an overall increase in gamma oscillations compared to neurotypical subjects. These findings have been interpreted as reflecting a reduction in signal-to-noise ratio caused by decreased inhibition, or possibly by a reduction in the number of positive PB cells. In our studies, we have therefore used Canisa figures to elicit gamma oscillations with which we follow our patients and gauge how they are doing when compared during this metric to behavioral screening techniques. Next slide, please. Faraday's law of electromagnetic induction, or simply Faraday's law, states that the voltage induced in a closed circuit is directly proportional to the speed of change of a magnetic field. In transcranial magnetic stimulation, or TMS, a capacitor bank is quickly discharged to create a controlled pulse of a very high current through a conductor. This current is as high as 10,000 amps. Capacitors are used to store energy and are efficient for discharging short pulses or bursts of current. When the conductor is wrapped to form a coil, the magnetic field of each turn of wire is added with those of its neighbors. The resulting magnetic field has polarity with a north pole at one end and a south pole at the other end of the coil. When a conductive material is added to the center of the coil, this helps to concentrate the magnetic flux in a well-defined and predictable field. In TMS, the magnetic field that arises from the coil varies between 1.5 and 2 Teslas, which is approximately the same as the magnetic field intensity produced by the MRI equipment used in radiology. Next slide, please. At low frequencies, and by that I mean less than 1 hertz or 1 cycle per second, TMS has an inhibitory effect. This effect may be due to its action of interneurons. Some of these inhibitory neurons have a geometrical orientation more favorable to the magnetic field lines produced by the coil, which induces currents along the axons rather than through them. When higher frequencies are used, and that is more than 5 hertz, all of the neurons within a cortical area are stimulated. That is, they are stimulated regardless of their geometrical orientation. And because pyramidal cells comprise 70 to 90% of all neurons in the cerebral cortex, the end result is that TMS becomes excitatory at higher frequency levels. In TMS, the influence of the magnetic field is restricted to a small area within the surface layers of the cerebral cortex, approximately 3 centimeters squares, something like this. Therefore, it is important to select an appropriate area or region of interest to maximize the effectiveness of the intervention. Among the many areas of the cerebral cortex, the dorsolateral prefrontal cortex has been closely related to abnormal functioning in patients with ASD. This prefrontal cortical region is involved in the genesis of executive functions, including, as seen in the slide, playing an important role in cognitive control, participating in supervisory care, synchronizing thought and action according to internal objectives, and providing signals to other brain structures to guide the flow of activity along neural pathways. In addition, this area is responsible for the inability to inhibit inappropriate behaviors that limit possible adaptive responses. Because the prefrontal cortex is widely interconnected with other areas of the cortex, correcting the function of this region could help normalize the function of its multiple interconnections across the entire brain. This is what I call a therapeutic cascade. Next slide, please. In general, the parameters of our TMS studies have used a coil in the form of the number 8 with low frequency stimulation, meaning less than 1 Hertz. As I explained previously, this low frequency stimulation has an inhibitory effect on the cortex. Because of its connectivity and role in executive functions, we have opted to stimulate the dorsolateral prefrontal cortex. Most studies so far have excluded patients with seizures or brain trauma. Participation has been limited to high-functioning individuals defined by an IQ of more than 70 and an age range of between 8 and 18 years. Outcome measures have included gamma oscillations, event-related potentials, behavioral examinations, and autonomic measurements. In our studies, we thought that the best control group would be a number of autistic individuals with similarities in their IQs and socioeconomic level, as well as matched by age and sex, and who were not subjected to TMS treatments. After completing the study, participants in the control group were offered active treatment. Next slide, please. In total, we have done about 15 clinical trials of TMS in autism, recruiting several hundreds patients, if not thousands. In this slide, we illustrate the study design of one of these clinical trials. It began by recruiting and screening 124 patients who were divided into different treatment groups. The control group was formed by a similar number of autistic individuals paired by age and gender who did not receive active treatment. The study required about 2,000 clinical visits, not counting those visits necessary for the patient to get used to the laboratory, the whole clinical setting. The study design in this slide emphasizes the time and effort required to perform each of these studies and why TMS studies take so long. So we proceed by baby steps. Next slide, please. Our results indicate that in autism, the evoked gamma activity does not discriminate between types of stimulus. while in controls, the early differences in gamma power between the target and the non-target of the Canisa figure are significant. These differences are normalized after treatment with TMS. You can see them in the slide upper right. In order to explain to all listeners the clinical significance of the results or how they help explain some of the symptoms of autism, I would have to say that in the brains of some autistic individuals, networks of overactivated and noisy neurons impair cortical connectivity between different regions of the brain. This makes it difficult for the autistic individual to selectively process the salience of any particular information based on its relevance. In this regard, a face, a flower in a vase, a house or a dog can all have the same relevance. We believe that this explanation is correct, as in other studies, our group has shown that TMS therapy results in greater coherence of function between distant brain regions, indicated here in the lower figure, right side of the slide. This improvement occurs in direct relation to the number of TMS sessions. Next slide, please. Task monitoring is an executive function. Being able to follow a task involves focusing on the task in question, remembering and following multi-step instructions, being able to detect errors, and instituting corrective behaviors when these errors are noticed. The ability to institute corrective actions allows people to avoid making more mistakes and helps them adapt to challenging environments. It is for these reasons that the first studies of our group on TMS in autism focus on executive functions that had to do with monitoring and correcting errors. The study presented in this slide was one involving 28 individuals, 14 each for the ASD and control groups. The active group received 12 sessions of low-frequency bilateral TMS on the prefrontal cortex. Results in ASD patients receiving TMS showed significant improvements in error detection and correction. The results suggest that treatment with TMS in ASD may improve executive functions related to error monitoring. More than anything, the study emphasizes that TMS therapy can change one of the central deficits of autism, that is improving its executive functions. Now, if you remember one of our first slides, the one with Declan Murphy, I can say that with TMS, we're moving away from symptomatic treatments to an intervention that targets some of the core pathology of autism and is able to normalize some of its more disabling features, as in the case of executive functions. As a note, we have subsequently reproduced these results in several other published clinical trials. Next slide, please. This slide demonstrates the effect of an increasing number of sessions with TMS on the error rate and post-error response time. It indicates an improvement that correlates directly with the number of treatments. The delay that is observed after making a mistake is a recovery strategy that helps maintain control over a task and tries to avoid future behavioral failures. In autism, this delay is significantly shorter prior to treatment, indicating the propensity to take repetitive actions without thinking about them. After TMS, this time is prolonged to within the normal range of values. This task has been of clinical importance when we follow a particular subtype of ASD patient, namely those patients suffering from impulsivity and other characteristics of an attention deficit hyperactivity disorder. Next slide, please. This is a screen photograph of one of my favorite oscilloscopes at home. It is a LaCroix Wave Runner that has as part of its research tools the ability to analyze recorded frequencies. The upper channel shows a wave that mimics an EKG. The x-axis represents time and the y-axis is the amplitude of the voltage. The plot comes from an arbitrary waveform generator, not a real EKG. The upper channel allows us to study linear parameters in the EKG that can be discerned in the time domain, such as heart rate and its variability. The bottom channel illustrates the frequency analysis of the previous tracing. In this lower channel, the x-axis is the frequency and the y-axis is its power. In the frequency spectrum shown, we can arbitrarily divide the tracing into high and low frequency components. Spectral heart rate analysis represents a measure commonly used in psychopathological research to evaluate autonomous cardiac control. Attenuation in the power of the high frequency component is sometimes taken as a parasympathetic control index and also as an indicator of limited psychophysiological flexibility. In autism, we have found deficits in modulating the high frequency range in different social tasks. At baseline, our samples of autistic individuals usually have increased sympathetic activity, as shown by their heart rate, upper channel, and a diminution of their parasympathetic tone, as shown in the attenuation of high frequency component of their EKG in the lower channel. Next slide, please. In several clinical trials, our group has shown that the application of low-frequency TMS to the prefrontal cortex of autistic individuals normalizes parameters of the autonomic nervous system, with an additive effect observed with increasing number of treatment sessions. This takes advantage of the fact that the prefrontal cortex exerts control over the limbic regions of the brain. The results of the intervention are manifested as a reduction in heart rate, seen in this slide as an increase in the EKG's RR interval, and an increase in heart rate variability, seen in this slide by an increase in the standard deviation of the RR interval. We hope that this intervention will serve as prophylactic in preventing sudden cardiac death and to treat the dysautonomic symptoms commonly seen in autism. Our results suggest that autonomous activation measures, as well as autonomous cardiac regulation profiles, could be useful in distinguishing certain subgroups of autistic individuals and how we treat them. Next slide, please. In different articles, our group has shown that TMS therapy provides behavioral improvement in terms of repetitive and aberrant behaviors. These behaviors are what we often see as manifestations of anxiety in this patient population. We're also very interested in following many of our patients comment that with TMS therapy, they have noticed improvements in the sleep disorders as well as in gastrointestinal manifestations. Next slide, please. These behavioral improvements are related to the number of TMS sessions. The higher the number, the better the behavioral response. This type of therapy has to be investigated as an alternative to the use of neuroleptics for the treatment of poorly adaptive behaviors. At present, TMS therapy has a few side effects, while pharmacological interventions, for example, neuroleptics, leads to a plethora of side effects such as weight gain, constipation, drowsiness in many of the children receiving them. Next slide, please. Our group has also examined possible synergism by combining the use of TMS with neurofeedback. Our studies have measured executive functions and behavioral measures. The results of our clinical trials have shown synergistic improvements that are very significant for executive functions, positive changes in EEG results, and an increase in the relative amplitude or power of gamma activity. Next slide, please. Before ending the lecture, I wanted to provide a warning note. A recently published book and a bestseller entitled Switched On and written by John Elder Robinson has idealized the treatment of TMS as a possible cure for autism. In the book, it is narrated how John substantially and permanently improved his empathy and emotional understanding abilities due to this therapy. After his first therapy, John tells us that while traveling home, he placed a tape inside his vehicle recorder, and for the first time in his life, the music caused an emotional reaction in him. John participated in several Harvard University studies. None of them were clinical trials, and they used individual TMS pulses to investigate brain functions. Individual pulses have no discernible effects beyond the stimulation sessions. Despite the conviction ingrained in John's narrative, we cannot claim that the effects of therapy went further than that provided by a placebo effect. Next slide, please. In finalizing this lecture, I would like to emphasize a point. Transcranial magnetic stimulation remains an experimental intervention in the field of autism as of today. No multi-center trials have been conducted with large enough number of participants to test its effectiveness and allow comparisons with other treatments. Likewise, participants who received TMS for autism have not been followed for a considerable period of time, and we do not know how long some of its positive effects last. So far, the US Food and Drug Administration, FDA, has not recognized the therapeutic value of TMS in autism. Those interested in obtaining more information can do so by reading some of our recently published books, Defining Autism or Autism Updated. Autism Updated was an attempt I made to answer all of the questions about autism that patients usually brought to my practice. You can also follow us through our blogs, scienceoveracupa.com, that is my wife or mine, corticalchauvinism.com. I must say thank you very much for your kind attention and patience. I hope that this little introduction to our investigation has been to your liking.
Oh, thank you very much, Dr. Казанова, for your very, very comprehensive and very, very interesting lecture. I really enjoyed as a medical doctor. I hope that our audience also enjoyed, even they are not, most of them are not medical doctors in the audience, but now we should go to the next session with dedicated to the questions and answers. Your technique is very amazing, and I hope that some parents who are in this meeting will have some questions to you. But please don't ask the professor for the other questions which are not connected with his presentation. Only for the transmagnetic cranial stimulation. Please don't ask him about other interventions, vitamins and other things. Only please, your questions or comments should be stressed on his lecture. Here we have one question from Nada Dupjačanec Nikolowska. She is my postgraduate student on Institute of Special Education and Rehabilitation. Does the effectiveness of TMS depends on patient age?
I would say that's a question that hasn't been researched enough. Our clinical trials, the age range was from anywhere 8 to 18 years of age. And we selected that age as a cutoff, starting at 8, because that was when the patients could participate and be screened for behavioral and EEG. We're allowed to pay attention, to follow instructions, and so forth. Younger patients, we had bad luck initially because we couldn't sit them down before a computer, and they couldn't follow the instructions and press the keys on the computer. I could say that we have experience on some younger patients that actually came to my laboratory, and I couldn't refuse. And we had some very good results with them. It's just that large enough samples have not been done or followed. I can say that my own grandson, he's very low functioning, and even when he was young, I did not allow him to go through the TMS trials. And that's because, especially for some individuals, and now I am going on a detour of the question, but I would say that the technique also has good results for those patients that are primarily high functioning. If you're very low functioning, if you have evidence of an anatomical abnormality, heterotopias, periventricular nodular heterotopias, and so forth, relentless seizures that may reflect the same, you cannot correct an anatomical structural lesion with a functional intervention. So in terms of the question, it would be very valuable to expand our studies with different metrics so that we could cover younger patients, and to add that thus far results, significant positive results, have been attained primarily to high functioning individuals.
Same colleague ask you, does other patient conditions can be contraindicated with TMS except some medications?
Yeah, I would say that there are no major contraindications. What we do seems to be enough in terms of safety measures by excluding those patients that have seizures. That was part of the ADA rules for the safety of TMS, and we have adhered to them. I could also add that even in terms of cortical excitability, I mean, we really use very low frequency of a stimulation, which is inhibitory in type. So even in this type of patient, we could actually provide the therapy because it could be fairly safe, but we have abstained from doing so. The other thing is that some people have been trying to attain inhibitory effects with TMS by using something called theta bursts that usually employ 50 hertz, a frequency of 50 hertz. We have found that even though it appears to be effective in terms of results, those higher frequency stimulations cause a lot of discomfort to the patients, and sometimes they may not come back for booster stimuli, which is another question well worth addressing, and that's how long does the effect last? And I would say that they last like from 6 months to about 1 year, and then you would have to get a booster shot. It's very similar to TMS treatment in depression, but you know, after you get your booster shot in 1 year, it may take you like 2 more years before you get another booster shot, and then it may take you like 5 more years before you get a booster shot, and then you may not need one forever, period. We're counting with the plasticity of the brain to correct itself, and that's the problem. It takes time.
Yeah, thank you. Thank you for this extensive explanation. Now we are going through the other questions, but before that, I would, we are in MSSA, we are greatly honored with your lecture because you give this lecture and you gave us advantage in front of Autism Research Institute, because the similar lecture you will have next week in US for them. But before them, you have a lecture for us here on Balkans. And the next
I would say, Vladimir, that it was extremely coincidental because
yeah, I know. Yeah.
The next lecture is actually this Wednesday, in 2 days.
Yeah, this
So
Wednesday. Yeah.
I was asked to deliver 2 lectures with the same title and about the same things, but for different organizations. And the next one is going to be for the ARI and the World Autism Organization.
But we are really honored because 2 days before them, we have opportunity to listen your lecture. Yeah. And the second question is connected with the Balkans. Is this method available in the Balkans? I know the answer, but please.
I would probably like to avoid that because I really don't know the answer very well. Vladimir, you may know a lot more. I have gone around the world, and I was part of the international consortium of Autism Institute. I was its president, and I know about all of South America, Russia, China. I do not know about the Balkans now.
Mm-hmm. Yeah, I think that is not available on the Balkans, and probably your team you should think about to extend your method if it's possible with some of colleagues on the Balkans to share your knowledge, because you have a great knowledge and your publications are very well known. I cited a lot of your works in my books published on Macedonian, and a lot of my postgraduate master students and PhD students know a lot about your work, especially on mini-columnar pathology in autism spectrum disorders.
Thank you so much.
Yeah, and now I would like to be much more interactive. I would like to ask my colleague and friend from Facebook. She's Macedonian, but she lives in Florida in US, and she's a professor on mechanical engineering, and she has 2 questions, and probably I will ask her to not shame and to show herself to get here with audio and video, if it's possible, Professor Magdalena, if it's possible. If not, I will say your questions. Is that possible for you to connect with us with camera and with your audio? Okay. Probably not. There are a lot of questions in the chat. Probably you can see them. But okay, I will read her questions. What are the negative effects of the magnetic method so far registered? The first one?
Well, they have been minimal. I would say that in the study that I quoted within one of the slides, where we started with 124 patients, we ended up with like 112. And the dropout rate was actually due to travel, because we have accepted patients from outside of our city. So they just dropped off for those reasons. I have had only like 2 patients that have dropped out because of side effects. One of them was a young child who was a track star athlete, and he sort of tripped over his own shoes while running and blamed the TMS. And another one that actually made him apparently hyper sociable, a good-looking boy, who after TMS, he, if anything, started dating way too much. But anyway, that would be a subject for another conversation. But the major recorded side effects of TMS have been in terms of headaches, because the magnetic field affects not only the neurons of the brain, but almost any sort of neural tissue in between. And it will stimulate the contraction of muscles, okay, in the temple area. So it gives rise to a tension type of headache, but to which the patients usually adapt fairly easily after like 3 sessions or so. There's also some complaints about the noise of the technique, because every time that we fire the capacitor bank, it actually makes a noise, and we provide for earplugs to the patients because of that. The side effects of seizures have been debated in the literature, and I must say that at the frequencies that we have been using the technique, the FDA has been behind us in supporting the safetiness of this intervention. So overall, side effects are few and minor.
Thank you. And the same lady, our colleague Professor Magdalena, she's trying to switch on the camera, but probably she has some troubles with that. Her second question is, in case you have researched how music and what type of music you have observed affected autistic person.
Well, I haven't done the studies. I mean, music has an effect in the brain, and I mean, if you go back in history, shamans, the African doctors, when they were beating their drums, they actually caused individuals, participants, to fall into a trance because of the beating of the drums. And there are techniques as of present for brainwave entrainment that use not only visual, but also auditory stimuli. So you can stimulate different brainwave rhythms with music. And I know that many people sell music for this particular purpose throughout the net, but I haven't actually followed or studied them. The only thing that I can say is that music has certainly been used as a part of therapeutic efforts by Guy Berard and his old school of auditory training. And I think that the music that they use is selected because of auditory audiograms that they perform in terms of the hearing of the patients. Usually, normally, when you study audition over the frequency ranges that we can listen to, like anywhere like from 20 hertz to about 20,000 hertz cycles per second, you will see a flat line in a normal individual. In autistic individuals, you have certain peaks. So what that music therapy attempts to perform is to flatten that curve by making patients accustomed, adapted to music of different frequencies. Again, I have only limited experience with all of that.
Thank you. Another one question from the colleague Nada Dupjačanec-Nikolska. Does other patient conditions can be contraindicated with TMS, except some medications?
No, I would say that seizures is the big no-no. Otherwise, most of the comorbidities of patients with autism do not exclude them from treatment. You know, I have a friend, Christopher Gilbert, who made a study over 1 decade ago where he studied a cross-section of the population in Sweden. And he said that about 95% of the patients that he examined had a comorbidity. 50%, got this one, had 4 or more comorbidities. You know, psychiatric, you have sleep disorders, you have gastrointestinal. None of those really contraindicates TMS treatment. And what we have found, if anything, is that providing this treatment, it actually improves those comorbidities. We have found improvements in GI abnormalities and improvement in sleep patterns, behaviors.
Yeah. Professor Magdalena asked the third question. If the human ear can hear comfortably approximately 20 hertz, how 50 hertz magnetic field is compared with the ability to hear 20 hertz?
I didn't understand the whole question, but I will start by saying that auditory frequencies usually start at 20. Yeah. Well, you have to have a super ear if you're able to capture anything that low. I think that truthfully, we could begin more at 200. And we really do not go as high as 20,000. That's the upper limit. I think that at my age, I'm lucky if I get 18,000 or 17,000. But what was the question per se?
If the human ear can hear comfortably approximately 20 hertz, how 50 hertz magnetic field is compared with the ability to hear 20 hertz?
Well, I think that she may be asking the question because our gamma frequencies are usually defined by like 30 or 35 to 60. Some people actually attach a hyper gamma on top of that. I will tell you that it's fairly interesting, but the brain is actually an inept piece of equipment in comparison to modern day electronics. Our brain works like from a few hertz to maybe 50 or 60 hertz. And modern electronics, especially now with cell phones, they go into gigahertz. So that would be like 10 to the minus 9 cycles per second. So our brain cannot compare in any way to that of modern electronic equipment. But that also means that we can influence it very easily. And we have mentioned that auditorily we can with photic stimulation. You see, the skull was made to protect the brain from trauma, but it doesn't prevent electromagnetic radiation from influencing the same. And even our baseline rhythms in terms of EEG are dictated by the environment. There is a particular frequency that is generated within the ionosphere, which is called the Schumann frequency. And it's usually about 8 hertz. And our baseline alpha frequencies, when we are awake and interacting normally during the day, is actually captured from the environment. So the brain is just an antenna for anything that we care to try to modify it with in terms of electromagnetic radiation. It can be done extremely easily.
Okay, just 2 more questions. Your presentation was really great, and there are a lot of questions and a lot of comments. One of the mother's child with autism, Miss Victoria, she said on Macedonian that she's very satisfied with your lecture, and
Thank you.
She will ask me after the meeting, but I ask her to directly ask you because I'm not expert in your field. But there are two more questions with one of my postgraduate students, Irena Stoyanovska. Professor Казанова, thank you for the thorough presentation. And have you observed abnormal gamma waves originating from other cortical areas apart from the DLPC? And if yes, what could be expected clinically with TMS applied in these areas?
Yeah, it's like a two-part question in reality. Oh my goodness. Gamma waves were first recorded from the occipital region. So in answer to the first question, you can't record it from other areas of the brain, and it depends on the elicited stimuli. We use the dorsolateral prefrontal cortex primarily because it's an area that is heavily interconnected to all other parts of the brain, including subcortical regions. And the thing is that you have a limited availability of an area to stimulate with TMS. So you need to maximize the effects of the same. And there's something with TMS that has been shown in terms of animal subjects and so forth, that whenever you stimulate an area of the brain, you also modulate the target areas of that particular region. And we thought that by stimulating the dorsolateral prefrontal cortex, we would be able to correct the functioning of that area of the brain, but slowly, over time, with plasticity, we would be able to correct the functioning of all of the other areas of the brain and subcortical areas. So that was basically it for the dorsolateral prefrontal cortex. I must say that Patricia Rakish used to say that the dorsolateral prefrontal cortex had a map of the whole brain within this particular brain region. So it has been of interest to neurologists and psychiatrists ever since Hughley Jackson in the 1900s, early 1900s.
Magdalena said thank you very much for the answers, for the previous three answers. And we are on the end with the last question from Madame Edina Tutic. Can you tell me, is there improvement in speech production with this method if MRI report says cystic, dilatate, perivascular space, parietally left? And thank you in advance.
I couldn't get it really the last part of the question. If an MRI had increase in the perivascular
MRI
space,
report is that there is in the brain cystic, dilatate, perivascular space, parietally on the left side on the brain. Well, cystic dilatation, perivascular. Perivascular space.
The first part, whether there was any improvement in terms of speech production, we didn't follow that as one of our outcome measures. I must say something very curious, that I mean, there's a high number of patients that are really nonverbal. I had a small series that wasn't really published, and it may only account for a minority of these nonverbal patients. But we found that in terms of a soft tissue x-rays of the neck, the epiglottis, the larynx, was displaced. So we had a number of autistic patients that could not talk, could not verbalize, had no production of speech, but it had an anatomical abnormality subjacent to the same. So they would never be able to talk, period. Okay. That may only account for a minority of patients, but I always thought that observation was significant. You know, in regards to the perivascular cystic dilation, you can see that in terms of anoxia. I think they are called Burkle-Robin spaces, and you can see them in terms of pathology. It can be congenital, or it can be due to anoxia or hypoxia later on in life. It goes along with a component of atrophy to the brain as a whole. But I am not sure about what was the condition of the patient. Considering that it may be a child, I have to guess that maybe this is a congenital effect. Usually you do not diagnose it with a name, okay, if you do not know the etiology. So I can describe it over at MRI and say that there is a cystic dilation of the perivascular spaces, the Burkle-Robin spaces. But unless I know the etiology, I wouldn't be able to provide a diagnosis. I have to believe that in her case, it's a congenital lesion. You know, another thing is that many of the patients with autism, they do have an increase in terms of obstetric difficulties. And there is a certain higher prevalence in terms of extreme prematurity. And all of those predispose the brain to lesions. I am not sure if this is the case. It's something that would need to be investigated.
I hope that this lady will be satisfied with your answers. You gave us very extensive answers and explanations of their questions. Mm-hmm. Now we are on the ending of our webinar, and I would like to thank you very much. I appreciate too much your time invested in this webinar of Macedonian Scientific Society for Autism. I must say to the audience that this is pro bono. You don't, and you never ask money to help in our work in journal, and also here in this presentation. You spent 1 hour and a half, and it's really appreciated by the MSSA members. Here Paula says that she's satisfied with your presentation. We really appreciate your time and your help, and you're one of the famous neuropathologists who works in this field of autism spectrum disorders. This is my personal opinion, and I hope that it's true. If you would like to say something for the end, and then I will finish this.
Well, Vladimir, for me, has been both my pleasure and my honor. Thank you so much for the invitation.
Yeah. I hope that
hopefully I will be able to visit you all sometime in the future.
Yeah. After the pandemic, you was planned for last year in May, but after the pandemic, we must change our plans. Paola organized a web conference in June, in the end of the June, and but in the probably next year or two, in the 2023, who knows? We'll invite you with great satisfaction. Okay, MSSI will continue it with to bring very famous names in the field of autism spectrum disorders. Our next speaker is Paula Bartolomeus. She will talk in May 10th, in the same time, in 18 p.m. or Central European Time, 6 p.m. And she will talk about reattach method and in autism. Also, I would like to say that to stay safe and to stay healthy, to avoid coronavirus and all complications from who are coming with this virus, with this little virus. And I would like to thank to all participants for listening you and for great discussion. We have more than 30 minutes discussion. I hope that you are very tired now, and probably you should continue with your work at your university. And now I will say goodbye to next webinar, and stay healthy and stay safe. It was my pleasure to have all of you here on our webinar. Have a good evening, good afternoon in US, and goodbye to next meetings.